Good morning again. It's another privilege to come here and present. By causing pain, because that's where I get my job. If there's no pain, then I will not have a job. But it's a joke. So I hope this presentation will not be painful. Great. I'm going to talk about advances in pain management, new insights, and new techniques. But doesn't mean other techniques like 2024 techniques are left behind. Maybe they're improved. And when you make a combination, sometimes it gives a good outcome. And remember, we are around patient pain management. Okay? So, this is my hospital in Rwanda. It's King Faisal Hospital, Rwanda. This the front side, and this is the back side. And we are going to start expanding the hospital up to 600 beds, and it has started already. Probably in 2 years we'll be done. So I'm inviting you to Rwanda to visit. So what we'll be talking about, historical background, and what is the situation today in terms of epidemiology, and I'll just show you how a doctor looks like today regarding pain, and how the patient looks like. And then we try to think and compare LMIC and low and middle income countries and high income countries. And then we talk about advances, and maybe we make a conclusion together. I don't have a conclusion. The conclusion will be from you. It's not mine. So let's go back to the history. Before yesterday when Professor was presenting, I liked the way he was going through the history, and I wish he would be the one to talk about the history. The history, me, as my age, talking about history, it's somehow unfair. Yeah, exactly. But it looks nice when he's the one talking about the history. And maybe coming back to, like, in my time, we were doing this. That's a very good comparison when you compare this. It's the prehistorical events, right? So in terms of pain, like in ancient cultures, pain outside the visible injury was caused by demons or evil spirits. People believed that. And I'm very sure today there are some people who are living in those years, in those ages. Like, they think pain without injury is caused by demons. And whenever I say that, in the name of Jesus, some people think like that. Huh? I will be sorry about their beliefs, but it happens back home. Some people, instead of going to the hospital, finding diagnosis, they go to prayer rooms, right? Does it happen here too? Aha. Okay. And then some cultures were using coca plant leaf for pain remedies. At least maybe. And the opium was used to relieve pain in Egypt, India, China, and other cultures. So that was many years, 1500 before Christ. That's prehistorical. And then as we advance, as we come to our time, 300 years before Christ, some were believing that the heart senses pain, but not the brain. Maybe it's a heartbreak. Who was Emmanuel? Where is the heartbreak pain? So they're saying the heart senses pain, but not brain. Okay. But some other parts of like in Chinese, acupuncture was first recorded in their books, in their medical texts. So, see, there's difference in terms of beliefs, in terms of what people know. And this is the time of discovery where people stand and dealing with something. I was saying yesterday that pain is a very sensitive topic, but less addressed for many years, even today. So people have been trying to find out how to manage pain. And look, 250 years later, some believe the central nervous system detects pain, signaling an underlying disease that needs to be addressed to alleviate pain. It's coming, right? It's coming. So they're trying to link what the central nervous system has or perceives to something that is happening that needs to be addressed. And that is close to us. So, and the use of electrical fish was used for headache, arthritis, and other pain in Egypt, Rome, and Greece. That's where the massage started. Like, they connect, they plug the fish. It's not a fish. It's electrical fish. It has just the shape of a fish, but it's like a electrical machine to do massage, right? They have a vibration, and they put on the arthritis, for mostly inflammation, but also was being used for headaches. I don't know if it was helping, but probably, yes, because that's where it was implemented. Okay. So we are now 1150 after Christ. Pain was a punishment from gods. Say gods, not G, capital G. With healing of it left to mortals. Can you imagine? Eh? That's not far from today, right? Not much. So some believe say, okay, this is a punishment from God. Something happened, then you are punished. It's not a physiological or physical or anything cause, but it's just spiritual punishment. But in the same ages, so first book of drug formulation introduced by Nicholas of Salerno, more than half of the formulas are related to pain remedies. So given the time it started being discovered, one of the formulas, many formulas in that book came, it was just regarding pain management. And then 50 to 150 years later, there was a documented use of narcotics for painful operations. We are getting in there, right? The age of exploration. Western culture viewed medical treatments coming from the East as related to the devil. So they have started their discoveries. They have started using their industry to mix and make some of the pain medications, but other who are using traditional, they consider as devils. Comes from devils. So this time the Europeans are mixing narcotic substance with herbs and apply to sponge for inhalation or so age of exploration is coming and people are trying to document what they are doing. So 1800, you see that morphine industry produced in Germany and the United States because they think pain can be minimized and relieved. Dentists, they give public demonstration of ether inhalation as a surgical anesthesia, analgesia. How many of you know about ether? Ether. Yes. So ether, I've seen some parts in Tanzania, there's a demonstration where they show how ether works, but they no longer use it. And then I was really interested in visiting Boston, where there's an ether dome. That's where they say, that's where anesthesia started. And they do simulation on how the ether was being used. There are videos, there are images. So that's where in 80s, 1846, that's where the ether inhalation was started to be used for dental surgery. So then, 2 years later, British obstetrician James Young Simpson proposes use of chloroform for pain in childbirth and cesarean sections. That's where we are still on the inhalations. It's just to numb the patient and do procedure. And remember, there was no hypnosis. There was no hypnosis yet. But that time, people were just trying to numb for pain only. Yeah? And where there's nothing, they were just having people like, and they just grab him and they do operation. Someone put something here so that even when he cries, there's nothing. But the surgery is done, the patient will suffer later and get healed. Huh? So, devils, maybe they are not happy. Sorry, no problem. I'm okay. I'm okay. I'll be careful. Do you see? Okay, good. So, 1953, people have been on pain training, on pain conferences. They know this guy. John Bonica. He died in 1994 and is the first comprehensive textbook on pain treatment options around the world. Has got a lot of awards because he has done like a compilation of all techniques, all medications, just to treat pain. So he's known. He has awards. He has the nominations everywhere, and people who are on ISP or who have attended conference, they know John Bonica. So he tried to take everything, like medications from China, medications from everywhere, and then he did compilation of those, and the textbook was out. So today, pain is individualized and can be helped through a multimodal personalized plan, a need for research to determine best approaches. Now we are trying to think of individualized pain management plan. And then we are involving patients in the management plan. That's how we are advancing. And it can be helped through a multimodal. This is the term a lot of people don't understand. Multimodal analgesia. Use more than one approach to treat pain, to address pain. Being acute, being chronic, being cancer, being any type of pain. Multimodal analgesia. So, 1990, health community recognized the need for more alternative treatments to pharmacology for pain relief. Still, we are on pharmacology. Few people have thought about non-pharmacology, but look, well, how many years? 27 years later, pain management collaboratory begins studies on non-pharmacological approaches to pain management. So people have been, so one of my failure in treating chronic pain is that I started giving medications to patients. And then, you give like 1 month, and you explain, you have this, if you do this, you stop, and this, and this. After 1 month, what happens? The patient comes back in the same pain. Sometimes the volume is higher than before. Are you doing a good job? Tell me, I'm asking. If the patient comes, you give medications for 1 month, and then after 1 month he comes back, the volume is high. The pain is more severe than before. Are you doing a good job? The answer is no. Because the aim of treating is for the patient to get rid of that pain and continues the activities, continue living with probably that pain because it's chronic, but without limitation of activities, right? That's the plan. But if you fail in that, so that's where I thought, okay, let's go for non-pharmacological and see if the patient can do something back home on his own and then get better, cope with that pain, and without limitation of anything. Good. So this is what we call multimodal, using opioids, non-opioids, adjuvants, regional technique, psychological, non-pharmacological, or just combining all of this can have a good outcome to patients. So from from 1600, 1680, 1800 up to today, there have been advances. But the question is, did we do a good job? Did we really adequately manage that pain? Because despite all discoveries, despite all advances, despite all textbooks, despite all laboratory, whatever, industry, anything, studies, fellowships, trainings, extra trainings, books, but we still fail in treating adequately pain. Am I lying? Is it because the pain changed the characteristics? Still the same, right? So let's see, probably something is missing, because this is a good sign that we are not doing a good job. How many, look, almost 21% of US adults are living with chronic pain. That's a big number. For those who understand the statistics, meaning this is a very good big number, okay? And 8 in 10 patients with chronic pain are affected by severe depression. Look at this, it's like this. So among those who have chronic pain, up to 85% have got severe depression. Normally when you see these numbers, it's in the US, but because they do a lot of studies, research, and this should be a very public health issue, right? And it's not done yet. 1 in 4 of people with chronic pain have been diagnosed with clinical insomnia. They don't sleep. 10% of the world's population is affected by chronic pain. What is the world's population? Huh? Is it 8 billion, right? 8. Eh? 8 billion. Okay, so 8 billion, that means 800 million population is affected by chronic pain. Isn't it a public health issue? It is. And look at what it causes. So up to $600 billion is gone every year in the US on chronic pain. So this just caused us to do studies in our countries, right? To see how many people are suffering from chronic pain in Nigeria. And remember, these are those who go to the hospital because they are recorded from there. And then we don't know what is happening in general. This is just to show you how probably you're not doing a good job. So today, a doctor today in a consultation room, when you have a patient with pain, in general, there's a limited number of doctors or physicians. And not every doctor is trained on how to treat pain, on how to assess pain. And pain is individualized, as you have seen. So if someone has a headache, every headache is not treated the same, right? You might have a headache, it's a tension headache. You might have a headache, it's a what? Sinus headache. You might have a headache, it's a migraine. You might have a headache, it's a tumor. You might have a headache, it's what? A lot of things. There's so-called cluster headache, different types of headache, but every headache is not treated by paracetamol. And how many of doctors give paracetamol for every headache? Or paracetamol-based regimen, whatever. Caffeine or whatever. Maybe caffeine is worsening the situation. So you see, this is a doctor today. We don't go like in deep by asking patients, going to the story, having time to do dialogue, and we are always looking for income, what we earn, what the hospital earns from us. The income, I mean, what we are called for. It's like we are called for to generate money, but not the main objective to have our patients feel better, right? So that needs time. They need a very good workforce. There's a lot of limitations around that. Okay? How about nursing? About nursing. How many nurses do care patients in the world? Emergency, in ICU, You see a patient crying and say, oh, why are you crying? Or why are you crying? We have given you medications. Huh? We can't give it more. We can't give more. That's not reassurance, okay? Try to think in your workplace, right? What happens? So this is the medicine today. We should look around and see what we are doing, if it's helping. Am I preaching? Eh? Great. So we focus mostly on technology, on imaging and everything, but mostly we lose this. Physical exams. We rely on radiological findings. We rely on what the patient tells you without even going deep. And we are losing this. We are losing this. With technology, with advances in technology, in techniques, in diagnostic tools, we no longer focus on physical exam. Right? It happens. So when you don't react, I feel like the message is going through. And what about the patient today? The patient who needs education about pain, who is going to teach, who is going to educate our patients? Because I was telling some of my colleagues, whatever hurts in the abdomen, it's not intestinal worms, right? It's not. Someone has abdominal pain and just goes around and takes some, So some will take the herbs and take because they think it's abdominal worms, intestinal worms. And then say, okay, I will see how it goes tomorrow. Some will go to the over-the-counter medications. They buy some medications and then say, okay, tomorrow I will be fine. And then tomorrow it gets worse. And the abdomen starts being distended. Huh? And then it goes to the traditional doctor, right? We call them doctors. And then they go there, they give them some herbs, mix everything, and then they drink for 2 days. Say, okay, in 2 days, okay, you have pain, but, don't worry, 2 days will go. 2 days, the abdomen gets worse. No gas, no stool, nothing. And remember, it was appendicitis. And that appendicitis, now it's ruptured, it's peritonitis. The patient will come from home in ambulance. That's the situation. You know why? The reason why is that patients are not educated about pain. Mechanism of pain, different types of pain. They should understand the mechanism. They should understand the neuroscience of pain. They should understand how pain can be due to different causes, right? Okay. And in terms of assessment, few patients in the hospital understand how we assess pain. So who is going to do the education? Question mark. Who is going to? Are we all understanding this? That's one question. Question number one. Question number two. So are we ready to go and educate our patients? Remember those patients, they are family members, right? Maybe they not come to your hospital, you go to the other hospital, and they will be treated the same as you. You will not be happy. This is our task, right? Okay, so let's just have a quick look on how low and middle income countries versus high income countries approach this issue. Look at availability of pain medications. It's limited in LMIC, and especially an opioid, analgesic. But here there's a wide access to a broad range of pain medications, including opioids. When you go to opioid use, this is another hot topic. There's strict regulations and limited availability, but alternative medications often used, sometimes not indicated. But here, it's widely available, used more frequent for severe pain. Non-pharmacological interventions, less commonly used or available, focused on basic interventions like heat, cold therapy. But here there is extensive use of physical therapy, cognitive behavioral therapy, and the other modalities. Healthcare infrastructures, limited, well developed. Education, limited training, comprehensive training. You see how different we are managing one patient, like a similar patient. You understand? And then cultural and societal attitudes. Pain management may be influenced by cultural attitudes towards pain and opioid stigma around opioid use, but here more acceptance of pain management practices, including opioid use through with awareness of risks. Access to advanced what therapies, limited. Here, access to a range of what? Of advanced pain management therapies. Economic factors, budget constraints, as we were saying, generally higher healthcare budget. You can see the money spent on chronic pain in the US is higher than higher than some country budgets per year. So you can't even compare. And policy and regulations, policies may be less developed, but here it's well established. So when you think about implementation of a program or pain practice in your region or area, think about these things, barriers. And when you discuss with the group, think of the barriers and try to take positive things you have and get a good outcome from them. Otherwise, this can cause depression. Looking at this, the practice, and looking at this can cause depression. So when I went to do my fellowship in pain, we were doing a lot of things. Some of the techniques I will show you, we were doing that. But I was always thinking back home, what will I be able to do? And when I got home, I had knowledge, I had skills, but no facilities. That's a total depression, I'm telling you. I'm telling you. And it could be a good debate. Is it really important to go and learn something that you will not do back home? Is it important? Debate. Right? It's a debate. Because after 1 year without practicing, after 2 years without practicing, you forget. And what is the benefit? So, it's a debate. It's not part of my topic. But just understand. So this discrepancy, like this, we like diversity, but this is the negative part of diversity. Sorry. So advances are just classified into this. Today, we have pharmacological treatment, advances in pharmacology, advances in biological therapies, neurostimulation and neuromodulation. Those are techniques, integrative and complementary approaches, advanced intervention techniques, digital health and telemedicine, diagnostic imaging, psychological and behavioral approach. And you can see in biological, there are a lot of things that is happening in terms of genetics, in joint pathology, inflammation, genetics, and nociception. Just looking at the genetics changes, doing mutations, all of those things, and then you change automatically. And then you go to psychological, where you work on the mood and emotions and think of how pain is catastrophized. Oh, wow. And then work on how to cope with the pain and stress. The other context is behavior. To improve sleep, diet, exercise, and to work on substance use. Because I've seen the number, 85% of patients with chronic pain have got depression. And what does depression do? Takes you to drugs, takes you to substance abuse, alcohol, takes you to, harming yourself than treating, than managing yourself. So this behavioral approach, psychological approach, and the behavioral approach, we work on that thing. And then in sociological, you work on social support, occupational therapy, education, and work on the income, because that is also another factor that takes you to aggravated pain sensation. So these are techniques. I will just mention them. These are neurostimulation and neuromodulation. You have technique. It's just about the needling and electricity. There's so-called radio frequency generation, where you generate electricity on and you try to do ablation of the nerves, where the electricity, we just do ablation. And it's a sciences you do, like depends, every 6 months, every 3 months, every 8 months, depends. And then you get numb, because you have like electrical shooting and neuropathic pain, mostly for low back pain. So this is neurostimulation and neuromodulation. It's use those apparatus. And here you have interventions like needling in the back. One example is like a facet joint injections, where you have inflammation. Some people just have injection of steroids there in the joints, so that you decrease the inflammation under fluoroscopy. Okay, this is advances. And then now, digital health and telemedicine. I don't know if in your country you have family doctors. So they screen the patient, and they have like a report, a very detailed report. They share with the pain doctor, and they can do consultation on video with the family doctor without being, taken to the place where the pain doctor is. And then you get the laboratory result. It's just sent through the networking they have. And then you treat, you do physical exam, and then you ask questions, and it's done. You do prescription, you do whatever. All the exams are done on the what? On the area where you were. So this is advances. This can be done once you have developed all these communication tools and this. Then some people will be talking with the patients, reading the radiological findings, and then discuss, ask questions without going there, because that's also another nightmare with the chronic pain patient. So this is also about integrative and complementary approaches. Actually, some of us, we take, for example, yoga and Tai Chi. How many of you think this can be beneficial for pain? You will be thinking, this is a religious thing, this is a Chinese thing, this is a whatever, Korean regions, and few people will adopt this in our region, right? It happens. So this is one of the complementary approaches, like cognitive behavior therapy, where you change unhelpful thoughts, decrease with outcome to decrease pain, acceptance and commitment, to accept pain, to cope with pain, and then you have more control over pain. What about the yoga and Tai Chi? This is focused awareness. You focus on something that is really important. You focus on meditation. You focus on good things, and then chronic pain relief. Mindfulness exercises. This is acceptance of thought, where you doing like a synchronization, harmonization of the body, spirit, and mind. Because most of the time, think about yourself. Think about yourself. When you have a loan, you put all of your thoughts on the loan, and you never progress, right? That's normal life. So mindfulness exercises, we just tell you to think of other positive things, so that you wash out all negative things, and then you continue living, right? So mindfulness exercise, acceptance of thought, this to improve the pain tolerance. And this is what I was telling you about the biological therapies. So where we work on genetics. And this is a neurostimulation modulation. We use needles and go directly to the point where the pain comes from. And then you numb the nerves or you put steroids, injections, whatever. These are techniques under fluoroscopy. So this is another technique where the patient is controlling the therapy. It's called patient-controlled analgesia. The patient have a pump. You regulate a pump. You put numbers of doses, and then patient will push by herself or himself. But you regulate so that the patient doesn't get overdosed. If you regulate like 15 minutes, within 15 minutes she can do multiple pushes. And then you know maybe that pain is not well controlled because it has done, despite all of those, the patient has done pushes. Controlled analgesia. Maybe this can help where we have limited workforce. Okay, this is an advances. And then virtual reality that works as a distraction. You have glasses, you have the mask, and then you can be taken to the beach. You can be taken to, it's a distraction. You think of the beach, you think of playing golf, you think of, playing, being in another world like illusions, and then you forget about you forget about pain. This is home-based virtual reality for chronic pain. There's a protocol with NIH that is coming out and still under investigation. So this is what the future has for us. Okay. What about the back pain? You use a robot for massage. Can you imagine? This is amazing. Huh? You have a massage, you regulate the robot, and then the patient goes there without any physical interaction with the doctor. And then even for injections, everything. This is the robot. And with the robot, the pursued pain management afterwards. What is this? What is this leaf? This is cannabis. This is medical cannabis, which has been used for, has been a lot of, a lot of cannabidiol or other cannabinoids in chronic pain. There's a lot of publications that, and you can see this narrative review which are said. 190. This is a topic, but medical cannabis in North America is being used, has been long to be used. So what is the benefit of that? To think of patients with pain, chronic pain, or cancer pain. They don't sleep. They don't have appetite receptors. What does it act on? Improving stress, improving appetite, improving anxiety. You want for these patients. Whatever medications you give will not affect that. But combining with the medical cannabis in a integrated way, because I will also add this. So this is the paper you can read. It's a recent one that details where they say chronic pain, the reported reduction of morphine, opioids, non-opioids, and over-the-counter medications, while less than 1% reported. So we consider more than 50%. Is it something to adopt? I don't know. Just be careful. Because there's legal implications. Advocacy is needed because there's medical perspectives behind that, right? Okay. So there's a lot of those ketamine we use for patients with the chronic pain that resisted to other medications. And the reason is behind is that these receptors, NMDA receptors in the spinal cord pain, and play a big role in central sensitization. So patients with central sensitization, the pain is saved, and you can't do anything to relieve that pain. So ketamine has anti-hyperallergic effect in a patient suffering from central sensitization. So not every chronic patient will benefit from having low dose ketamine, but those who have great. So with this, are we going to adequately treat our patients with this? I don't know. I don't know. So these are my references, and thank you very much. Murakoze, that's in Rwanda. And asanteni, that's Swahili. Okay, so if you have questions, please. Thank you very much.
Is this one painful? Yes, now it's painless. Thank you very much for that wonderful presentation. Sorry about that. And we are so sorry for the incident that happened the other time, because you did not appease the God. Next time. Thank you very much. That's a wonderful presentation. We really enjoy it, and we know we settle down and go through this again. I'll just give room for few questions for people that want to ask questions. Do you have any question in the house? Any questions?
Yeah.
Okay. Someone asked a question. Move today.
I remember.
Okay. All right.
Yesterday and today, I've quite enjoyed your presentation. I'm concerned about pain, because I've suffered from pains. But let's put that aside. In my many times, operative patients or
Hello, sorry, we cannot hear the presenter again.
And that's why they say we have given a lot and we don't want to give it more. So there's a concept in terms of mechanism of action of pain medications. So that's where multimodal analgesia is needed. So how much, what do you give? Because there should be a clear instruction instruction on how to give pain medication. You have given, for example, this so-called preemptive analgesia, where you give paracetamol before surgery, which will decrease the amount of opioids you give. So there are different techniques. When the surgery, like he said, there's 20 minutes before the end of surgery. By the end of surgery, the opioids will be just on the top of their mechanism of action, right? And we know that patient will not have pain afterwards. Pharmacological approach, if you think you have giving on type of surgery, ice compression in orthopedic surgery can be important, right? Distraction can be important. Music can be important. When I talk about music, it depends on which kind of music. Because as they say, there's some music that causes cancers, right? That opens, revives the cancer cells, right? So the music selection can also be important in decreasing, improve factor for having post-op pain. So it's just multimodal. You have to think of what is given and clear information, because if you are a PACU nurse, you should have clear information from an anesthetist. What is given? What is the next? Is the duration? Thank you.
Good morning, everyone. Morning to first. Dr. Gaston, thank you very much. Beautiful presentation. Okay. Can you hear me now?
Yeah.
Yeah. From your presentation yesterday and today, I wonder if you will ever have a student that will fail your course, because the way you teach is so cool. Sleep like a baby. I tried it and it worked for me. So can we encourage other people to use, so that it won't be that you are taking patients away from their doctors? I told you yesterday, from January till now, I've not taken any analgesic. And if I compete with you in dancing, I know I win, because I have the power.
Yes.
So
yes.
I don't want to advertise, the product. But some of my colleagues here, I put it on the platform and some of them came for it and they use it. And if anybody is interested, I'm ready to. Yes.
Yes. Actually, a big number of my patients with chronic pain, back pain, lower back pain, them on heat compression. I mean, affordability of the techniques, because some, they use infrared, infiltration. But you know the water bag. You know a water bag, right? You put hot water, it's sealed, you just seal it, and you put like something not to burn you, right? And then you relax your muscles. And the big percentage of back pain, it's mostly muscle spasms. Have you seen that? You have got something like radiculopathy, whatever, you have seen the discs, protrusion, all those things. And then from that time, let me tell you the mechanism. And by that time, you start sitting in a position where you feel better, right? Eh? You start sitting in a position where we call it antalgic position. The antalgic position, you squeeze your muscles, you are putting your muscles in a shape that is not originally, And then by the time you are not sitting in that position, the muscles want to come back to their normal shape. What happens? The filaments, we sometimes, because of that position, will be stuck. They will be no longer what? Contraction, right? The myosin and the actin are no longer, right, contracting, which causes muscle spasm. And where there's muscle spasm, it's acidic. There's no cellular muscle cell respiration, oxygenation. Then there's acidic, and there's no ATP, right? And then there's a lot of magnesium into the muscles. That's a lot of physiology. And then magnesium in the muscle causes pain, spasms. The treatment is what? Heat. Either can be heat, can be muscle relaxants, which is worse because you'll be always on muscle relaxants, or injections of magnesium, because magnesium will just take calcium back, right? Or put ATP to regenerate the movement. So these are, you need to understand the physiology. This I explain to the patient. There's an option. I can give you this medication and it will be forever. If you don't change your gait, if you don't change your position, right? I can give you this. You'll be in the car, you can put the water bag. You'll be sitting in the house, you put the bag. When you are in the bed, you put the bag. Wherever you go in the conference, you put the bag. Then your muscles will be relaxed. So myself, I go with my bag in the car, in the office, wherever I am. I can have my bag when I'm in a crisis, having chronic pain. So think about that. And the advocacy you are doing about, using non-pharmacological approach, very important. Thank you very much.
All right, thank you very much. Sorry, what's going on? Okay, maybe there's a new therapy there. Thank you for a great job. I just want to do it okay, all of us here. Thank you. Since it's your mic, it will work. It's an appeal I'm making to every one of us. We are in the enterprise of science. One of the things that makes science advance is transparency. It's not about worshiping any tradition or sectional interest or any form of bias that we think must be left intact. I want to encourage us to please be more open. I'm speaking to my dear sister. You spoke yesterday, you've spoken today. You did not describe what you said worked for you. Science can never grow that way. I'm sorry if I sound harsh. You need to be open
That is what then makes or creates opportunity for research. There is a difference between innovation and research. The moment we keep things secret, they are not available for testing. Research is not necessarily something up there in the sky. It is that you tried it, it worked for you. Another person, we document it. Another person does, we document it. And we document it for several people. Then we say, what was the cause of the pain? Because you don't just treat pain in isolation. And then you document it. When we've done that for X number of persons, we can now say that as part of therapy for this condition, 40% of persons responded to this pain therapy. 90% of those who responded to that therapy were people who had 1, 2, then another person takes it from there, does more studies. And then more and more. Then what happens? Evidence builds. The only thing that research does is to provide evidence. It doesn't bring in, it doesn't matter whether it's a doctor, nurse, a physiotherapist, or anybody likes it or does not like it. Knowledge gives us or makes us more skilled in what we do and provides more evidence behind what we claim. We cannot just say, oh, this is right, this is wrong, because I am this, because I am that. No, it is what is the evidence. In fact, I believe if he had more time, he would have told us about acupuncture, for example. What we just need is openness, transparency, more research to provide supportive evidence, especially when we don't have any clear information about what you have tried to have caused harm. You may be surprised that somebody else may try it, the pain will increase. Another person will try it, it will get better. Research will now find out why did the pain increase in that person. Then we might be able to do something that will enable that pain to be relieved another time. So please, let's be open. And let's be transparent. Let us seek evidence and let us all get better. Thank you very much.
Thank you, Prof. Thank you very much.
We can do better. We can do better.